and to officers and to the Cabinet member. So without any further ado, I will move on to the agenda. Item 1 is apologies for absence. I think we have some, Liz.
Yes, Chair, we've received apologies from Councillor Michael Locke, Councillor Susan Jones and Cheryl Philpott.
I have to say we also have Councillor Susan Jones's apologies as well, which is the reason why I'm sat here. So if you were wondering why, I guess. Item 2 is disclosures of interest. And if there are any, will you put your hands up and show us, please? Can't see any.
Yes,
Oh, sorry.
Chair, it's just a general. My daughter works for social services, so it's a general interest.
Okay, thanks, Jeff. One thing I didn't do was ask people to identify themselves around the room so that those people who are online will know who's here. So I'll start with myself, Councillor Paxton Hood-Williams, chairing this meeting for Sue Jones at the moment.
Liz Jordan, Scrutiny Officer.
Dave Howes, Director of Social Services.
Tony Pedder, Independent Member of the panel.
Amy Hawkins, Head of Adult Services.
Hello, I'm Andrea Preddy, Principal Officer, Community Integrated Services.
Good afternoon, I'm Sharon Jackson. I'm the Interim Community Integrated Services Manager. I manage the therapy staff that work in the community in Swansea, as well as some hospital discharge liaison nurses as well. Pleased to meet you all.
Louise Gibbard, Cabinet Member, Care Services.
Alan Jeffrey, yes, Councillor, Uplands Community.
Thank you. Item 3 is a prohibition of whip votes and declaration of party whips, which we have to have there, but I still don't understand what it means, and I know Chris will tell me one day, will you, Chris? Item 4 is the minutes of the previous meeting. Everybody I know has had a chance to have a look at these and read them. Unless you have any comments or have anything you want to raise, are you happy to accept these minutes, please?
Yes, Chair.
Yes, Chair.
Thank you. In that case, I'm assuming that they're accepted. Also, there was one letter associated with that, and with those minutes, you'll have had a chance to look at that. I don't know if you have any questions arising from those. Not seeing any, so therefore I'll move on to item 6, which is public question times. And ask Liz if we received any public questions.
We haven't received any questions, Chair.
Okay, thank you very much. Which moves us nicely onto the agenda properly then, which is item 7, the discharge from hospitals, and how health and social care work collaboratively on this issue. For members' benefit, and Councillor Jeff Jones will already know this, Governance and Audit Committee in their June meeting had an item which was Audit Wales Urgent and Emergency Care Flow out of Hospital in West Glamorgan Region report. This was presented by Audit Wales officers at the time, and last week Audit and Governance had a follow-up response from a West Glamorgan officer, Kelly Gillens. So I can assure you there's a lot of interest being taken in this matter, and we would be very interested to hear what you've got to say. So I'm not quite sure exactly who's going to take us through this at the moment.
Yeah, I'll just kick off if that's okay, Chair, and then hand over to others. Yeah, as you say, this is obviously, incredibly important topic, which has got quite a lot of, quite a headline grabbing topic in recent
Indeed.
months. And as you said, you've had that report come to audit committee. So hopefully this report today can provide a bit more of an update on that. And I think we've got a really good story to tell in terms of how, things have been quite challenging, but we've made some fantastic progress. So we've got Andrea and Sharon here to take us through the report, which outlines the work of the Adult Services Home Affairs Social Work team, which supports hospital patients across the region, including our post-discharge assessment. Sorry, it's a lot of big words of this. Assessments in community and reablement settings. The report details our integrated integrated approach with our health and third sector partners, and the role in delivering our national discharge to recover then access model. The benefits of early discharge and community, and it outlined the benefits of this early discharge and community-based recovery. It highlights the trusted assessor role, residential and home-based reablement services, and the function of the integrated discharge hub in streamlining patient transitions. It also presents our performance improvements, as I mentioned, in Swansea, including a significant reduction in discharge delays and enhanced coordination of care. So we're really good to bring this report. I know this is something that the panel requested that we talked about. So I'll hand over to officers to take us through the report.
Just before I do move on, I notice we have been joined now by Claire Taylor, who is the Regional Director of Llais Cymru. Very pleased to see you, Claire. Very welcome always to attend this meeting, and Child and Family Services as well. If you want to, in that sense, you're very welcome, as I say. Obviously, Llais, as I understand it, is basically taken over from the Community Health Councils, and we'll be interested to hear your comments whenever you want to make them. Thank you.
Thank you.
Thank you, Chair. Again, I'm Andrea Preddy. I'm the Principal Officer of Community Integrated Services. Part of my responsibility is being responsible for the social workers that are based in the Home First team, which is Morrison Hospital, Singleton Hospital, Gosainen Hospital and Neath Patawbla Hospital. We work closely with our health colleagues. We work to what we call the discharge to recover and assess model. We work collaboratively. We have really good working relationships which have improved, I would like to say, over the last 12 months. We have what we work with an integrated discharge hub. It is called IDH, but for you today, I'm going to call it the Integrated Discharge Hub, where we have professional people in the hub, which include a social worker, a lead nurse, physiotherapist, occupational therapist, and we discuss each referral that comes into department, and that referral then goes on to a pathway. We have been working towards a trusted assessor model, which you will see in the report, which is about to be signed off, that we can use it a little bit more than what we are. At the moment, we just use it for Bonamine House and T Westfield. We work together at the moment. We are looking at a lot of our policies, and we are able to contribute to health policies, and I think Sharon will discuss that a little bit further. We are totally scrutinised with our pathway of care delays by Welsh Assembly Government, and I'd like to say at the moment we're in a good position. Over the last 6 months we've worked incredibly hard with our health colleagues to try and improve the pathway of care delays. We had a day out yesterday, myself and other senior members of the health board in Cardiff, with other local authorities and health boards in Wales, and I'm pleased to say we are really in a good position. I picked up some email addresses from some of my colleagues yesterday where I think that we could improve again a little bit further around the work that we're doing, especially around possible delays, for instance, with mental capacity assessments. But the main thing that I think you'd like to hear is that we are definitely improving and in a good position. I'm going to hand you over to Sharon, because Sharon's just going to talk a little bit more around the trusted assessor role and the integrated discharge hub. Is that okay?
Can I talk on D2RA?
Yeah. Can I cross that?
Hi everyone. So just to recap, so I'm Sharon Jackson. I'm the Interim Community Integrated Services Manager. So I am employed by the Health Board, but I am employed and I sit in the integrated role, so between health and social care, and I manage therapy staff that are employed either by health and social care, and I also manage some of the nursing staff that are responsible for some of the flow and some of the admissions into Bonamine House as far as the trusted assessor model goes. So if I just recap back to the discharge to recover to assess, because that's how we've all come together with how we're working. And as the report details, you will be aware about all the benefits of this discharge to recover to assess model. And it is quite a shift, and it is a public shift as well regarding when it's right for somebody to leave the hospital. And the benefits of bringing people out of hospital as soon as they're ready to move on to the next destination and they don't need acute medical treatment is obviously, we know the evidence that people recover much better at home or in a place that's similar to their home as well. We know that they're much less likely to have infections. We know that they will be able to work collaboratively with the staff to set their own goals, because once they're in their own home, they know they're in the home, they know what they need to do there as well. And those conversations are much more effective and efficient when you're in somebody's home and when they're at home supported by their loved ones as well. So, obviously it does empower people's, independence and autonomy and voice to treat them at home as well. So that's really what D2RA is about. Discharge to recover to assess is about. It's bringing people out as soon as possible. And it is quite a societal shift with not that the hospital is not the safest place to be. Once people have been treated for their medical problems and their acute problems, we do want people to go home as soon as possible because they are at risk of hospital-borne infections and further deconditioning with just the environmental setup of the hospital as it is. So ultimately, D2RA is the benefit to the person. And then it's also the benefit to the wider collective community by ensuring that we have appropriate flow, that we don't have ambulances building up at the front door waiting to offload individuals because we can't get people home as well. So that's ultimately what the D2RA is about. And then the report also details the pathways that we encourage people to come out on, and the pathways are between pathway 0, 1, 2 and 3. So there's the 4 pathways, and ultimately, as you can read in the report, those pathways depend on the type of support that the individuals require when they come out as well. So pathway 0 is that they regain their independence or they come back out to a service that's already involved with them. Pathway 1 is very much where we're working collaboratively with our reablement home care, supporting individuals to come out of hospital, working with them with a package of care. And hopefully reabling them so they don't need ongoing formal services when they recover. And then we've got Bonamine and TU Westfield, which are our pathway 2 beds. And basically we look to put individuals into these homes where they need more wraparound support and a bit more intensive intervention. And then we've got pathway 3, which is our very complex pathway where sadly people are not going to recover, perhaps to where we think that they regain their independence. And we've done quite a period of work with the pathway 3s because with people that go into hospital, if we get a referral for them later on down the journey, when they've been in hospital for quite a few weeks, sometimes we've missed an opportunity to get them back out of hospital. So we've done a piece of work, and I'll come on to the integrated hub in a moment, where we looked at some of these people that were going down what we call a pathway 3. And because we weren't assessing them quickly enough and addressing their needs quickly enough, and they were being deconditioned in hospital further, we ended up with people going into care homes permanently that might not have needed to had we assessed them earlier. So earlier on, a few months ago, the integrated discharge hub was born, wasn't it? From a period of work that we did, and we all came together for a week, and we tried something different to see if it would work. And what we did, so the integrated discharge hub is based at the front door of the hospital, so in Morriston Hospital, and it's based around the front door, what we call front door wards. So they are the assessment unit, there's the emergency department, there's an acute medical unit as well. So we've got these wards in Morriston, and what we've done is we've put health and social care staff based ourselves at the front door, working alongside our hospital colleagues. So what we're trying to do in the Integrated Discharge Hub is when they come into hospital, or even prior to when they're actually admitted into hospital, we're working in partnership to identify the needs. And if they don't need acute medical intervention to keep them in the hospital, we're providing that wraparound. So Andrea's team with the social workers and the home care reablement are on site to assess. So we're doing what's called proportionate assessments to work alongside and try and bring people out so they don't get, unfortunately, admitted then into a ward that they don't necessarily need to be in. And then unfortunately, additional harm occurs to them because they should never have been admitted to a hospital bed. So that's the nature of the Integrated Discharge Hub. We have our third sector colleagues that work alongside us, so our CVS wellbeing colleagues. They look at things like, identifying if a person needs a food parcel to support that discharge home, whether they need urgent cleaning company, because often one of the barriers with reablement home care is that the person's home is in such a disarray that it's not safe to send reablement carers in. So they'll look at doing cleaning services, furniture packages, so another thing that our colleagues do, and food shops and things like that, and checks as well, and that links in with those wider social groups as well. So the Integrated Discharge Hub operates Monday to Friday. We identify referrals. We sometimes see people face to face, or we'll speak to the hospital therapy staff, nursing staff, and then we'll receive referrals in, and then we will pass them on and communicate with our community receiving services as well.
That's right. Yeah.
So that's generally the Integrated Discharge Hub that we deliver. And then if we talk about the trusted assessor model as well, so we have got, as Andrea said, we've got a trusted assessor model already developed within Swansea, and that was in play prior to Discharge to Recover to Assess. Historically, there's been a very good collaborative relationship, and Andrea and the social work colleagues have worked with the what we call the discharge liaison nurses, who are part of my team, and their nursing colleagues. They work within the community and the hospital site to support people, to get them, to support them on their journey home and to make sure they're on the right pathway. So the discharge liaison nurses are the trusted assessors for Bonamine House and T Westfield. And they identify the individuals for the beds there, and they complete the trusted assessor proportion, and then it goes to our social worker colleagues and our residential care colleagues to look at that referral to make sure that they've got appropriate staffing needs to accommodate, and then they're accepted through, and that works really well. The other thing that we're working on then within the hospital is a trusted assessor model where the hospital staff can eventually refer directly into our community receiving services. We've started that work with a trusted assessor form. We've had agreement from all our key stakeholders in health and social care that they're happy with the form. And then so that's our first phase. We've agreed the form. And then our second phase now is rolling out some training and piloting it. First of all, at the front door, the hospital, and then eventually in what we call the downstream wards, or what we call the back door. So when people are coming out of hospital after a period of time.
Sorry, just having a bit of a Amy Hawkins, Head of Adult Services. I was just going to sum up really some of the performance information that you'll see in the report as well, if that's okay. So you mentioned, Chair, at the beginning that you had the update report audit committee that Wales Audit Office had done on delay discharge, and the period that covered was April 23 to March 23 to April 24, didn't it? And I think what our colleague Kelly will have said, I suppose, is about the improvements that have been made so far, and that's been illustrated already by Sharon as well, and Andrea, in terms of the work that's happened. And you'll see in the report, just in the last 6 months, so the data we've given you today is much more up-to-date information, I suppose, because we wanted to just tell you where we were. So from March 23 through to August is showing that we've seen a significant increase and improvement in the amount of people on delayed pathways. So there's been an improvement on the amount of days people are waiting. There's an improvement of 45%, and that delays has dropped from 18,000 hours down to 9,000 hours. Sorry, not hours, days people are waiting. There's been a 59% reduction in assessment delays, particularly around hospital social work teams that Andrea was mentioning as well. This is involved, and we've had some additional investment in these teams as well. So really focusing on all the actions that you will have heard about in the Wales Audit Office report, but really that this work in the last 12 months is really ramped up, I suppose, in this space, and we've really focused on this and in a true integrated way, you know, as demonstrated today by we've got colleagues from both teams.
Thank you very much for those presentations. What I will do now, I'll throw it open to questions from members. I don't see any hands. Oh yes, Jeff, sorry. You've got your hand up?
Yes, I have. Yeah, thanks, Chair, and thanks to the people actually here today with the information. Yeah, you know, referring back to the audit report, I think you said 23, 24, there were a number of, shall we say, deficiencies and so on. We seem to have got over that. You know, this trusted assessor role seems to be extremely important. I know we've actually mentioned training and so on. With regards to the expertise on the medical side, you know, do you actually get consultants actually signing off? I think you mentioned a form in part of the presentation. You know, do you have to get things like that actually signed off in the first instance, on top of actually pulling everything together that, you know, there are facilities available to discharge, shall we say, to, and so on. So I don't know if you can you answer that, please?
Thank you for the question. At the moment, the trusted assessor are trained nurses that complete the form. So they have the medical expertise. If there were any issues, obviously they would consult with the consultant, but at the moment they complete the trusted assessor form. More often than not, you know, this standard is very, very good. However, I'm not saying it's perfect. We've had 1 or 2 assessments that we've questioned, and rightly so, with somebody coming into one of our establishments. But if there is an issue, obviously we try and resolve it with our partners straight away with the content of information on the assessment form. But it is what we call the DLNs, the designated lead nurses, that complete those forms. Yeah.
Okay. Yes. Thanks. Sorry, somebody.
Yeah, I'll come in as well on that, just to clarify with the consultant and the medical. So once the person has been deemed not to have a medical requirement to remain in the hospital, the MDT will then be informed. So the consultant or the doctor still decides on whether somebody should be medically admitted to a hospital or remain in a hospital. So just to clarify that bit, once that decision has been made, it's the wider MDT, social work, nursing, everybody that makes that decision on how that person should be supported out of hospital. And that trusted assessor form is filled out at the moment by the discharge liaison nurses, but is due to be able to be filled out by a social worker, a therapist, or a nurse, another type of nurse as well. I hope that clarifies that question.
Thanks very much. Chair, I can see Chris has got his hand up. If I can ask one other thing as well. You also mentioned in your presentation as well that this team works Monday to Friday. And going back to the, shall we say, the audit report in 23 or whatever, they actually mentioned one of the shortfalls was that people are perhaps not discharged on a weekend. You know, is the intention to actually make it a 7-day week team?
So we do support discharges across the weekend. So the team that I manage, the therapy team, works 7 days. So they do support discharges coming out, and discharges are planned out of hospital on a Saturday and a Sunday as well. The integrated discharge hub itself, unfortunately, at the moment doesn't work across 7 days, but we would like it to. But at the moment, obviously, we've had to start somewhere. So the staffing and the capacity that we have in the service at the moment is 5 days, but the aspiration would be, with funding, to 7 days. But we have reablement home care that receive in discharges over the weekend. So that does happen, for your assurance as well.
Thank you.
Chris?
Thank you very much, Chair, and thank you very much for the presentation. I may be totally wrong here, but I've gone through the presentation, and I see there's a lot of the professional input in it. How much input do the family have? And if there's no family of that patient, do they have someone who acts as some sort of guardian ad litem, or what? So there doesn't seem to be much in here about how you consult either with the parents or the relations of the person that's coming out. I was wondering if you could highlight that for us.
Yes, thank you for the question. Obviously, if the patient has capacity, we always speak to the patient first about their wishes. You know, we listen to their voice. But if there are issues with their mental capacity and the family need to become involved, we always include the family in discussions. And even if the patient requests that a family is involved, we will always ask them to attend specific meetings. So ultimately, though, you know, it's the patient's voice that we like to listen to first.
And I completely understand that. It's just that it doesn't show any reference in here. That's all I'm saying. And I think at some stage, you know, for the completeness of the report, if we could actually say something about that, it would be beneficial, I believe.
Yep. Thank you very much for the question.
Alan, do you want to ask a question?
Yeah, thanks, Chair. Not so much a question, really, but to say thank you for a well-written document report. I mean, short enough, just 10 pages. I could keep my concentration that long. Thanks for that. And it was fully, well, it was clear. I could follow the each of the 40-odd paragraphs clearly. And I'm glad to see that you identified all the acronyms that were in there as well, because they used to drive me up the wall at one time. But, you know, with the D2RAs, the DLNs, IDHs, and so forth, at least you've identified what they mean. And the graphs, although they look like very much like those kind of speech recognition oscilloscopes to recognize the speech, but at least it did show the trend. The only thing I was a bit confused is the first graph with the straight line through it. Did that seem to show a median or an average? I didn't quite, 7 below Welsh Government. I didn't quite follow what that represented. Thank you, Chair.
I can just explain to you that was the expected Welsh average, the line across, just to make it clear for you.
So it would have been ideal then if you could have followed that line. Does that make sense?
Yeah.
Yeah, or better than, indeed. Yes. Yeah.
I've got to pay careful look, and I haven't seen any more hands going up. So I'll ask just one question, I think, if I may. Because during the pandemic, to ensure that bed blocking was minimised, as I understood it, people were being discharged literally as soon as possible and were met by a social worker on the doorstep. This obviously required a very close collaboration between the health board and social services, but it seemed to me that that major collaboration was about the only good thing that was likely to come out of the pandemic. Having said that, that collaboration seemed to disappear, and it's now good news, in fact, that it's beginning to restart again. All I can say is I wish you well with it, and I'm very pleased to see that from the presentation. It's good to see that the graphs are all moving in the right direction. Just make sure to carry on doing that, please, if you would. Sorry. Oh, sorry.
Do you want to go to the councillor first, and I'll come in at the end, Chair?
Jeff, do you want to come back in?
Yeah, thanks, Chair. Yeah, I'm glad it's actually working, and I know it mentions bottlenecks and so on, and it's perhaps at an early stage, perhaps too early a stage to assess really. I know it's a dirty word, money, but we revolve around budgets at the end of the day. Is this going to actually save money? I know it's going to be a big plus with regards to accelerating people actually, shall we say, through the system. But have we any information relating to perhaps additional cost, or will this be less cost and so on at the end of the day?
Who wants to come in on that one?
In terms of our target operating model for adult services, the D2RA, the discharge to assess model, certainly supports that, because as Sharon was using the example of people sort of deconditioning or going into residential care homes, perhaps because of the time of the discharge and things, when we know that it's better if people stay at home and independent. Another part of the model which helps towards the financial picture is around supporting more people going through reablement. So we know rather than people going straight from hospital into a long-term package of care at home, which is good, people are at home with a package of care, but we also know that if they have a period of reablement first, our performance is showing us that that package of care is sometimes no need for that going long-term. People just have it for a short period of time, or if they do need it, it's been right-sized for them of what, so really specific to their needs. So that is more cost-effective. But generally our cost modelling, I think the hospitals do a lot of it around the costs of the beds. I don't think that always necessarily reads across in terms of the sort of social care savings on this, but this is a part of quite a large piece of work we're doing in our regional space in the Western Morgan space with the Regional Partnership Board around our community and older people's programme. So some of this is linked towards our joint work in this space around the money. So yeah, more work in this space to do, but this is about efficiencies and better models as well for people.
Okay, thank you.
Thank you, Amy. David.
Yeah, I was under strict instructions not to ask any tough questions, but I couldn't resist. Just that, and is it genuine about the understanding of us all collectively? So we've seen really positive graphs on there. The improvement that's been made over the last 6 months is best in Wales. So brilliant. What's realistic though? So is it that actually you could reduce theoretically pathway of care delays down to 0 or single figures in terms of either numbers or the amount of days lost? My assumption is no, but what is realistic? How close to an optimum model are we at the moment as a best guess? What could we be looking for? Amy's already referenced target operating model. Our target operating model aspirations would be the best that we could possibly be. As a local authority, I'm sure that's the aspiration of the health board as well. And then we want to deliver that through that integrated arrangement. What do we think is realistic though? We've halved. It can't keep going down in that exponential drop. What could we achieve?
I think realistically, the last 6 months we've come through spring and summer, and we talk about, you know, winter pressures being around all year, but I think we have to be realistic. We are going into winter season. It is going to be difficult to keep the figures as they are now, but I think it's working with our colleagues, and I think we both understand each other's roles, and I think, you know, we're in a position with, if we talk about working collaboratively, I've worked in the health space within social care for many, many years, and I will say we're in a position now, today, that our working relationship is better than it's ever been, than ever that I've experienced, because we are sharing our data, we're sharing, like I said, we understand each other's pressures from a health perspective, from a social care perspective. But getting back to the course, I do think it's going to be difficult. We will try our best to try and keep the figures as they are, but we have to be realistic and expect some spikes. But ideally, we will try and get the figures back down again. I don't know if Sharon's got a different view on it to myself, but that's my personal view at the moment. We will be expecting to have a few spikes through the winter. Yeah, oh, sorry.
Yes. So a pathway of care delay is classified, obviously, that once somebody's deemed fit to leave the hospital, then 48 hours after that point, their stay then becomes a pathway of care delay. So we have 48 hours. And as far as I know from the conversation with the Welsh Government, the direction was that the expectation is to get to 0. But is that realistic with the capacity we've got in the system? Now, I think 48 hours gives us some scope to get care packages. I think we can do better. But as Andrea said, we are heading into winter period. So I think that's a very difficult one to establish. I think we'd be very happy to stay around where we are, to try and get lower. The expectation and the request that we do get much lower towards that 0. But that's probably going to take an even greater shift in how we're working at the moment as well. And it relies on, you know, there's things outside of our control as well. So when we look at pathway of care delays, I don't know whether you've seen them in the Welsh Government, but there's different categories of a delay, and that can be a social work assessment. It could be equipment delay, but it could as well be a family delay, because the family need to go and visit a care home and they can't get to a care home in time. So it relies on a whole system approach. That becomes very difficult. It's not just social workers working as quickly as they can and our home care colleagues getting through, but we are doing some changes within our internal services. We're redefining our reablement home care offer. So we're hoping that we'll continue down this journey, but I don't know whether we can say how far we're going to get.
Oh, can I just come in out? All I can say is we will try our best to try and keep it at the best level that we can. Ultimately, we have to continue our good working relationships with health, but we have to be honest, and you know, we are definitely going into winter pressures, and as we know, things can become quite difficult during these periods.
Okay. Mark, you had a question?
Thanks, Chair. I have every confidence in the commitment of the team there. Just beginning with the winter pressures and in terms of the spikes, have you got plans in place, or could we plan a response for these winter spikes? Is it a question of resources? Yeah, that's it. Could we plan for the spikes, or is it a little bit on the late side now? Thank you very much.
Oh, yeah, I'll just come in on that. Yeah, be assured we've got a winter plan. It's been developed as a part of the Regional Partnership Board as well, particularly looking at winter pressures. It gets submitted to Welsh Government in the coming days, actually. So it's been put together with all partners and looking at different aspects of how we're working. It's really building on what we've done at the moment. It's also, we've had some additional funding to support with our hospital discharges that's particularly come to social care as well. So we're looking at additional resources that we're putting in as well. So this is the kind of work we do. I know our colleagues from Llais actually are on the call, and I know they've got a winter pressures event coming up as well that our colleagues will be talking at as well. So just to give the public some more information about that as well.
Thank you very much.
Thank you. I'm not seeing now any more hands up. So in that case, what I will do is I'll say thank you very much to the three of you, Amy, Andrea and Sharon, for the presentation. It is interesting, obviously. It really reinforces what Kelly Gillins was telling us last week in Governance and Audit meeting. So hopefully you're going to continue moving in the right direction. I'm sure this is not the last time we're going to ask you to come back to talk to us on this matter, but we will look with interest to see what goes on, what comes forward going onwards. Thank you. On that basis, I'll move on to item 8 on the agenda, which is the work plan for the year. Members will have had a chance to look at it. You've seen it now for some time. We haven't changed it recently. I'm just wondering whether you think there is any need for changes. If so, please say so now. Remember to put that on. That was the item 9 is obviously the report that went to council last week. And as you well know, David took it there, and that is why it's purely on the agenda for information. At council, a number of questions were raised by members in respect of its contents. I certainly didn't raise any queries myself in the meeting, but there were members, a number of questions were raised by members in respect of its contents. As I say, I didn't raise any queries, but I did assure members that the 2 social services scrutiny performance panels would continue to approach our approach of robust challenge and support. And I also asked Dave to pass on to our grateful thanks to all his staff for all their effort and work to support our vulnerable people, residents, young and old in Swansea. Don't know if you want to add anything more, David, to that.
No, I don't think so, Chair. I mean, clearly I'll be happy to answer any questions that committee members had. You know, they weren't asked in council, but the reality is you scrutinise performance really robustly throughout the year. So it'd be a surprise if, you know, at the point that you get the annual report that you've got new and different questions to ask. I would absolutely encourage you to carry on being as robust as you have been for many years now. It's one of the reasons that I can stand up in council and say, I've reached the conclusion that we continue to be safe and effective. Part of that is because the council does robustly scrutinise performance in this really important area on such a frequent basis and to such a high standard. So it's really important to me that you carry on doing that, but I know that goes without saying. But if there were any specific questions, either now or subsequently, more than happy to follow up with committee members. Thanks, Chair.
Okay, thanks, David. I am not seeing any hands going up. In which case I have to say that brings the meeting to the close because it's the end of the agenda. And I look forward to seeing you at the next meeting of this scrutiny performance panel. Not quite sure when it is, Liz, but you will tell me, I'm sure. whenever it is anyway.
28th of October.
Pardon?
28th of October.
20th of October?
Yeah.
Okay, thank you very much.
Yeah, if I give my apologies for that meeting, it's half term and we're going away for a couple of days, but Councillor Gwilym will be here for her item anyway.